So again, good morning or good afternoon, depending on where you are today. Welcome everyone. My name is Angie Grover. I'm co-founder and COO of Metopio. Just a quick bit of housekeeping before we get started. For today's webinar, we will have the chat on and we will be managing it. So if you have any questions or comments during the presentation, you can go ahead and put them there. The audience will be muted and we'll have time for questions at the end. If we don't get to your questions, we will definitely follow up with you outside of the webinar. The slides and recording will be distributed after today's call, and that's like literally always the first question someone who joins us late puts in there. Will the slides and recording be distributed? Yes, they will be. So let's get started. Many, if not all of you joining us today, know where you live shapes your health, but those differences are often hidden in broad averages or state level data. And I like to start all of my data webinars by acknowledging that data is really about real lives and it gives us the opportunity to have strategic and meaningful change. And I think all of the things we're going to talk about today really will drive that home. And I just really want to reflect that community because that's where the data comes from. And this conversation is especially timely. According to the American Statistical Association, most of our federal statistical agencies have lost 20 to 30% of their staff since 2009. And every day we are fighting against the misinformation and trying to earn back the public's trust. So let me take a look at that poll and share those results. So when we share these results, you'll see lots of folks are, losing access, obviously, inaccuracies, lack of local or granular data, and declining public trust. Those are all issues we will touch on in some way, shape, or form today. So we're glad that you've all joined us for this conversation. Today, I have the pleasure of introducing two excellent data experts, Ben Spohr and Heather Blonsky, who will dive into these topics and give us their perspective on the data landscape and how to best leverage data going into 2026. Ben Spohr is the Program Director for the City Health Dashboard and Congressional District Health Dashboard at the NYU Grossman School of Medicine in the Department of Population Health. These two websites provide relevant, actionable, nonpartisan health-related data to policymakers free of charge at the state, city, congressional district, and census tract levels. Ben joined the project as manager of the data team in 2019 after completing his PhD at the NYU School of Global Public Health. Heather Blonsky is Vice President of Data here at Metopio and leads our data curation, integration, and analytics efforts to provide the community context needed for clear understanding of community social needs and health status. Heather has unique experience previously working with the Cleveland Clinic and in building Vizient's Social Vulnerability Index that is used widely across the industry. She has a real passion for bringing clarity to issues of health access, neighborhood resourcing, and designing actionable interventions to improve health outcomes. Thank you both for joining us today. And I'd like to ground our conversation in our shared love of all things data. So Ben, I'm going to turn it over to you and ask you to share a little bit about the work that you do at the City Health Dashboard.
Yeah, happy to. And thanks for inviting me, Angie. So, the City Health Dashboard is a public, freely available website that produces over 45 tailored measures of health and drivers of health at the city and census tract level for over 1,200 US cities. We are housed at the NYU Grossman School of Medicine and funded by the Robert Wood Johnson Foundation. You can see the link to the website underlined there. Slide, please. So this is a dot map. It's not a particularly effective form of communication because places where there's lots of people living, there's too many dots and you can't really make them out. But like Northeast California, parts of Texas. But there are over 1,200 dots on there, I promise you. And we put this graphic on the right side of your screen just to brag about how popular we are. We've had almost 3 million page views, 689,000 sessions. What we really like is that there's a big gap between the total users and number of sessions, which means people are coming back and using the tool, which we love. And slide, please. And then this is a very busy slide, but I put it up to sort of ground us in the federal data sources that I'm going to talk about a bit today. The metrics related to birth and death, like breast cancer deaths or teen births, those come from the National Vital Statistics System at CDC, where we analyze the country's birth and death records. A lot of the social and economic factors, like children in poverty, broadband connection, neighborhood racial ethnic segregation, come from the U.S. Census American Community Survey. And then a lot of the health outcomes, like high blood pressure, independent living difficulty, food insecurity, come from the CDC Places project. So something like 3/4 of the metrics we provide folks via our websites are sourced from federal data sources. So we are watching them as closely as we possibly can because they're a huge part of what we do at the City Health Dashboard and Congressional District Health Dashboard. Angie, I think you're muted.
I'll catch
That
up.
is that is always the case, right? You're on mute.
Yep.
But Heather, obviously, we're peas in a pod when it comes to the work that Ben leads. So
Absolutely.
can you take a moment to talk about how Metopio uses similar data to advance
Sure.
the work of our partners?
And yes, definitely two peas in a pod. We use all those same sources, all those same federal sources. We have all those same concerns. That's why we're here. But our focus is really bringing as much as possible into that community context. So we do supplement those federal sources really with the intent of supporting meaningful community health needs assessments, really actionable improvement plans. And so that means state data, that means local data, your own data for our customers who have sources. Whether that's their community partners, whether that's their own internal data, surveys that we help them with, surveys that they've done before. And I really like that focus on the surveys, both because it brings in that surveillance data like the BRFSS, the BRFS risk factor surveillance survey that feeds places, but also that community voice, that the prioritization that you can do with your community input. And so lots of different sources, lots of different ways to come at the very same topics and yeah, with the same concerns.
Well, and as you know, we talk about those federal sources. What we wanted to do is start our discussion today about, for reflecting on this past year with the new administration, what those data releases looked like, and some of the interesting observations we've made. So, Ben, I know that you talked about places and ACS. Could you just take a minute to reflect on what happened this year and maybe what you're
Mhm.
expecting going into 2026?
Yeah. What happened this year? That's a great question. What did happen this year? So I'll start with well, I'll focus on the three data sources I mentioned that our project primarily relies on. The first being CDC Places, which Heather accurately points out is fed by the Behavioral Risk Factor Surveillance System. Behavioral Risk Factor Surveillance System is collected by states, but paid for by CDC, collected by states, usually mostly at the county level, though there's state data as well. The states report it back to CDC, who then puts it all together, checks on the data quality, and then pushes it back out through the BRFS release uh, uh, infrastructure. And also, it's then downscaled, analyzed to smaller geographies by the CDC Places project. The entire CDC Places team was riffed in the first round of riffs earlier this year, shortly after the inauguration. A lot of the work for the CDC Places release for the 2025 data release had already been completed. And so the CDC Foundation sort of started to carry the torch there and brought us through to the release of the CDC Places data, like 2 weeks ago, which was scheduled for August, but a combination of the rifts and the government shutdown slowed it down a lot. So that team is no longer there, but there's a foundation out there that's taken a substantial interest in maintaining access to the data set. U.S. Census ACS got delayed by the government shutdown as well. They were meant to be released maybe 6 weeks ago or 2 months ago, but they're now going to be released. No, correction, they're usually released in December, but now they're going to be released in mid-January. And that's barring any other delays. We haven't heard about any other delays. My biggest fear for the census is that people are losing trust in the government and government data. And so when someone knocks on their door asking a bunch of kind of personal questions, that they're less likely to answer. So the robustness of the estimates is going to be lessened. And then finally, it's the vital statistics system, and that data is produced by the nation's birth and death records, with the states aggregate and report to the federal government. A lot of those folks were riffed during the government shutdown, but then there was a court order to restore them. So right now, we're not aware of any impacts on the staffing for the National Center for Health Statistics, which organizes the vital stats data, but they have been put in the crosshairs. And so we're watching that closely. The good news, I'll try to end on a happier note, is that because these large federal data sets require so much time and effort to collect, like if you think about it, asking a whole lot of people across the country the same set of questions and then writing down what they said and then organizing it, like takes forever. A lot of the data meant to be released in 2025 was already close to finished before the changes enacted by the current administration took place. We are watching closely for 2026, especially for CDC places, and trying to keep a close eye on how reluctance to answer these survey questions may affect response rates to the census. And because of how long these data take to mature, I guess, to become available, we are also looking at whether these changes to the federal data infrastructure could have impacts even beyond the current federal administration. So we're watching it closely. All the data came out this year that was expected this year. Next year, we're hoping is the same. There's reason for hope. There's reason for doubt.
Yep. And I wanted to throw into that point you made about the reduction in force, the people who are laid off and not rehired, is that is a ton of expertise, a ton of really skilled work that is hard to replicate. And this is something you and I have talked about before. The states do a lot, but to have 50 states doing the same thing, oof. that's that's more than a lot. That's something that needs to be coordinated. And so that's my biggest fear, and my biggest fear going forward, especially for the places data, is not having that team that really keeps it on track and keeps it going. We still have a lot of data coming out of the states. It's not going to be the same. It can't be the same.
And that's one of the things that we wanted to know from you all. I'm going to launch one more poll and just ask you, when this data is delayed, how's your organization most likely to respond? Because, we do still need to do our work. We still want to be data driven. And so part of the continuing conversation we're going to have with Ben and Heather is, okay, we've set the table. We know that there's some reason for hope and some reason for skepticism. What can we do to make sure that we're informing our work as we go forward? So I'm going to give you one more moment to finish that poll and let us know what you think while I tee up the next question for Ben and Heather, which is, as we think about what options you have to continue to understand your community and tap into those resources, where do you guys go, or where are you thinking that those resources could help our participants on today's webinar look for data to drive their work? And I think that's maybe Ben at the federal level, Heather maybe at the state level.
Sure. Want me to go first?
Yeah, and I'm sharing those results so you can take a look,
Yes.
at
And
where people are
that
really
first
looking.
one, rely more heavily on state or local administrative data, is really is my primary response, really. That and the surveys, I love a survey. But really to say that there are lots of people at non-federal levels who are interested in the exact same topics. And that could be your state government doing what they can. It's still not going to be the same, but it doesn't mean it's wrong. It just means it's really hard to map across the country. But then also your local partners, your local collaborators who may not be, a statistical organization, may not be, a government or body, but they may know their area really well. And so to say, we're a public health department, we partner with all of these other resources. If we want to know about food insecurity, the food bank knows a lot about food insecurity. And if you want to know about homelessness, the network of homeless shelters, crisis intervention, and housing assistance know a lot about homelessness. Now, that doesn't help you compare yourself to every other city in the nation, but that tells you a lot about your local landscape and the needs that are there and where you can really intervene. And so for the day-to-day work, what you have to do tomorrow, that can be an incredible source, even if you have the federal data. It doesn't replace it, but it does give you a lot to work with.
Yeah, it's just a testament to both local government and public health work has always been about resourcefulness and scrappiness, right? Even when we weren't facing sudden and substantial changes from the federal level. And so talking to the food bank is great, right? Talk to the local experts. For us, we really rely on those federal data sources. So our version of scrappy resourcefulness is trying to figure out ways we can compensate for the loss of federal data sources if they are lost. We are confident right now that we cannot really replace, for a lot of reasons, what the federal data infrastructure was doing. But there's four approaches we've been thinking about and investigating, and one of them is seeing what states release themselves that we can that release publicly that we can sort of grab and try to knit together, right? And fill in as much of the map as we can, acknowledging that the publicly released data sets are often not what the feds use because the feds have access to data prior to censoring for confidentiality issues, right? Because they are very careful about not releasing privacy information. There's also a lot of fancy statistical techniques that can get you from state or county or whatever down to a smaller geography, often called small area estimation methods, which was one of the big innovations of the CDC Places project. And we're like PDQ hiring and investigating and working on our small area estimation techniques. People always think about AI as well, and I'm kind of an AI skeptic because I don't think that if I ask the computer, "What do you think about this?" and the computer agrees with me, then the computer's right. Like there's a little confirmation bias. But a lot of these foundational models that big tech companies are putting together could fill in dark spots on the map. The problem with that is how do you validate it if you don't have a reference data set? If the federal data set that you would have compared it to is gone, how do you know that it's not like a hallucination by the machine? And then finally, electronic health records have grown in popularity, are gaining a lot of momentum. And there's a tremendous amount of information available through electronic health records, which are the records produced when people go to a doctor, right? Now that all the medical notes are put in digitally. Can we analyze those to figure out what's going on with disease outcomes? And the answer is yes, if we can adjust for the biases inherent in EHR. Not everybody who lives in a place goes to the same doctor, right? We know that, for instance, men are less likely to go to a doctor. And we're starting to understand that, for instance, chronic diseases, chronic conditions are overrepresented in EHR. And so we're working on how to adjust for those biases and whether that adjustment needs to vary across place. So none of this is going to replace what we had with the federal data sources if they go dark, but there might be stopgaps.
I totally agree about the EHR, and I think we could get very technical here. I won't. but but just in saying that if you're only looking at things that happen in a hospital, you're only looking at things that show up when somebody has contact with the healthcare system, you're missing everybody who either has, sort of subclinical levels of whatever, or has gone a while without seeing someone, or doesn't have the resources. And those are the ones that I'm really concerned about because you've now left off everybody who doesn't have insurance.
Premiums are going up right now, right?
Yeah, I
The
know.
subsidies are expiring. And so it's such a good point that it's becoming more of a convenient sample when fewer people can
Exactly.
access medical.
Exactly.
Well,
So
and Heather,
not,
do you
yeah.
want to just talk, building off that, just talk a little bit about the work that we've been able to do with claims data with that de-identified
Mhm.
aggregated data set, again, recognizing it's coming
Yep.
from hospital ER. So all of the things you guys have already talked about, but how
Exactly.
we've been able to partner to use that across public health and healthcare.
Yeah, and that's one of my favorite sources. Again, it is not perfect. It is totally not perfect, but it does tell you a lot about who does show up, who does have something that they can't manage at home, especially when you have ER data, ED data, because that does include people who have not had the resources to manage something at home and end up in the emergency department despite their best efforts. And it really gives you an area where not only do you get that view of people who show up in the emergency department with a complication of diabetes, for instance, where a good primary care course of care prior to that could have prevented it, but also gives you a point where you could intervene. And again, we're going back to this idea of what are we using the data for? It's not just to know, but what can you do? And I find emergency department visits and preventable emergency department visits is one of those measures that can move. And can move faster than some things, because if you have that intervention that really does loop people into primary care or does the outreach to make sure that they can maintain their health in their own lives, that's one thing that will actually improve, is that emergency department visit. And there's a ton of interest in it because those are expensive. Yeah. And they're never the right place. Nobody wants to be in the emergency room. Not even the people who have to be there want to be there. But it's always the last effort. But that's one of my favorite uses of it. It also gives you some view into how much money is spent on healthcare and how much money is spent on healthcare, again, all the way at the end of that continuum where the intervention might have been 10 years earlier, might have been 20 years earlier. So it's one of my favorite sources. It's always fun to wrestle it to figure out why this state and that state have nothing in common. But ultimately, when you're looking at your local landscape, it's one of those key features that you kind of have to loop in if you can.
And before we move on to our last topic, I do want to ask this question, and maybe Ben, this is for you. But Lisa asks, what about various imputation methods that don't rely on AN to fill in the missing data? Are those still useful? Do you have a point of view on that?
Yeah, I think that they are still useful, and depending on which academic you corner in the elevator, some will argue that the small area estimation methods like CDC places are an imputation method, right? And so those in a way fill in spots on the map because they give you more granular geographically parsed data. I think that those methods are better understood, have been out in the world for longer, and so more people have had a chance to critically review them. Perhaps less prone to inexplicable AI hallucinations. However, they are still going to face the lack of a gold standard comparator if some of these other data sets go away, right? So we can use models that we think are robust and have proved to ourselves are robust, but without that gold standard data set from the feds, or even some of the other data sets that we don't compare to, but we use for adjustment of our estimates, right? The way that BRFIS and NHIS talk to each other, National Health Interview Survey talk to each other. Our confidence in those imputation methods are lowered just because we can't really do the checks we used to do. So Lisa, the short answer to your question is totally valuable still, and also both AI and non-AI imputation methods will face some of the same challenges.
And I'm totally the statistician in the elevator who's going to say that small area estimation is imputation.
That's why I have you guys answering the questions.
There's nothing wrong with it. You just need to know what you've done and
exactly
and be able to justify it.
Well, I'll just ask if anybody has any questions. We're getting to the top of our half hour, 30 minutes go really, really quick. When you're talking about a topic that you're passionate about, if you have any questions, please put them in the chat. Before we wrap up, we do really feel passionately. Obviously, we do this work because we care about the communities that the data reflects. And I wanted to ask you both, what can our audience do or think about doing to be part of this conversation? So, what ideas do you have, or what do you know that's happening that they should think about engaging with?
I'll go ahead, Ben.
Sure. Well, we've got some great links in just dropped in the chat. One of them is a report by the American Statistical Association saying, here's how things have changed for federal data recently, and including in reference to their last report, which was released in 2024. And it's like I wouldn't read it right before bed because it will put the fear into you. But they do recommend that you go talk to your policymakers. And I heard a tidbit on a podcast once that if there are policymakers that if they hear from 6 people on a topic, it really grabs their attention because they actually don't hear from people that often. So in that line, the CDC Foundation, the Friends of NCHS, both of those are foundations that do advocacy and provide funding for these federal statistical agencies that produce the data we rely on. And so you can make a donation if you want to, but also you can just like go see what they are advocating for and figure out, think to yourself, do you want to sign on to that? And then if you're looking to keep up to date on the federal data sources, there's the Federal Data Forum you can sign up for and get like the up to the second info from all the people keeping their ear to the ground. I will also say that we have our other website, the Congressional District Health Dashboard, congressionaldistricthealthdashboard.org, will give you all the data that we have on the City Health Dashboard, but at the congressional district level, and link you out to your representatives so you can call them and say, these places' data are 3 years old. What's up? And then they will hopefully do something about it.
Yeah, I totally agree about advocacy. And I'm going to have a local answer too, because it's me. But yeah, knowing who your local collaborators are, knowing who is interested at your state and local level, who may be official data sources or may not, but where you can really share that burden and rely on the people who know their topic the best and not have to recreate the wheel. That's always going to be my favorite answer.
Well, and as a recovering lobbyist, advocacy is so important. If you think about who your elected officials are, they have to be experts on about a million different topics. And so to Ben's point, bringing your expertise and telling your story about how you actually use this data to make their communities better is really powerful. And there's another question. It's a good question to wrap up on.
Mhm.
We have a question that says, if most, if not all the vital stats data are from the states, why can we not just get the data from the state because it's more timely and more accurate?
Yeah, it's a great question. We've looked into it, and the short answer is that these vital stats data are produced by the states and then reported to NCHS. They're not necessarily released by the states. The
Right.
way we access them is by going to the restricted data center where you have to put your phone in a lockbox, and there's all these threatening signs about going to jail if you write down anything and take it out of there. The states don't have the funding or infrastructure to stand up a restricted data center the way that the feds do. So we can use data that's publicly released by the states, but those data will be edited. Some information will be removed to protect privacy. And so it's not as complete, and not all states will release data publicly. Some do. New Jersey state health data, NJ does a great job of releasing these data to the public. We can't get them from every state, and what we can get is not as good as what we get from the feds.
Yeah, same. It is, if you're lucky, you live in a state that has it and you can get it and it's perfect. And they'll release it to you because you're a public health department, or they'll release it to someone because they're a hospital. Frequently not the same data to each. And then you start trying to piece it all back together. But if you're not lucky, there's nothing.
Yeah. Well, I really appreciate this rapid fire half hour. Thank you, Ben and Heather, for sharing your expertise and lending your insights. Thanks to everyone who has joined us today. Metopio does sponsor these learning webinars. We do series that bring you experts like Ben and Heather to inform your work and talk about the issues we're facing collectively and what you need to improve health outcomes in your communities across the country. If you'd like to just know what our next learning series is, go ahead and take that poll answer. Ben, thank you very much. Heather, thanks everyone for joining us, and I hope you have a really fantastic holiday. We'll do good things together in 2026. I'm sure of it. Thank you so much, everyone.
Thanks so much.